So I will talk about something which is in part overlap with Nils, but also is a different approach. It's signatures, which is a combination of biomarkers versus single ones, and it's most of it, or all of it, is in blood. And very briefly then, I'll go through some of the strategies. I'll give you some examples, if I have time, both on cancer. I'm sorry, no diabetes today. Complex disease like autoimmune disease, SLE, and then some conclusions about this. But first of all, why are we doing this? In our case, and this is fact from WHO, is that 1/3 of all cancers could actually be cured, according to them, if they were detected and treated early. And also the treatment is more efficient when we can start it earlier, even prior to clinical symptoms. So this is the driving force for us. The dream scenario for us is blood, easy to withdraw. Obviously, the test format has to be sensitive and reproducible, as Niels alluded on. The cost, this is dollar per quality adjusted life year. I'll show you one health economic study we've done. Hardware format, if it's commercially available, it's much quicker to the market. And I think this is also perhaps the most important thing, the clinical utility. Does it solve any clinical problems? And you know, as scientists, we're always in love with our own technology and a way of doing things. And then when we come to the clinic, they say, well, you know, that's fine, but we do it this way. That's not so nice. So I'll talk about proteomics, no genes, for a number of reasons. And we haven't really, why haven't we succeeded? There was a study from the Plasma Protein Institute, 1,261 biomarkers. No one is routinely used for molecular diagnostic of cancer. And then somebody say, well, what about PSA or so on? But they are not routinely used for screening. And to our idea is that a single barcode doesn't contain enough information. Okay, so I'll show you then, this is some of the FDA-approved cancer biomarkers. I was just in contact with the FDA because this is an old table, and they don't have an updated table, believe it or not. But if you look at the sensitivity and the specificity, which is really defining the accuracy of a test, and sensitivity is the frequency of correctly classified patients, in this case with cancer, and specificity is the ones that doesn't have cancer. And as you can see here, you can go through the line. You can see that it's 70, 90, 80. The combination is not very impressive. 50% is guessing. And I would consider anything above 80 fairly good, above 90 excellent in sensitivity. The only thing that sticks out is this one for ovarian cancer, where you have a combination of biomarkers. And this doesn't, of course, prove the fact that I'm saying that signatures are better, but it is an early indication because this is from 2006. There will be a new report from FDA later this year, and also from the Personal Medicine Coalition, which is also coming out this year with more updated. But it shows the point that I'm trying to make, that single biomarkers are not very good, and none of them are actually used routinely in the clinic. Okay, this is an example of information content. And I don't think you can say what this actually is. But if you increase the information content in a picture like this, eventually you don't have to be a bioinformatician to see what it is. And this is the point that we are trying to show then with biomarkers, protein biomarkers in blood. So how do we do that? Well, we have worked for many years now trying to set up a multiplexed ELISA, basically. But it's a miniaturized. You can see here that each drop here disappears after about 2 seconds. We can spot in automated way, non-contact printers. And what we spot are these antibody fragments, which has been developed over the years in a number of different library sizes using phage display. And they are then spotted down, and you have this type of bio or microarrays. And eventually, when you develop it, you have a pattern that you try to understand what it actually means. And the sample that you need is very little, 1 microliter of serum or plasma. The limit of detection is actually better than an ordinary ELISA, and there is a number of theoretical studies of this. The idea of this was published '88 by Akins, so it's not a new thing. The things that have been happening over the last 5, 6, 7 years is that this has now been quality controlled to the point where the reproducibility and so on and so forth is acceptable. And if you look at the microarray formats today, this is how it looks. And this is just a blow-up to show that the signal-to-noise ratio is quite good today. In this case, we have almost 14,000 data points on a micro slide. And you can have a number of sub-arrays, as we have here. We have 14 different ones, so you can actually run 14 samples in one. And you can run, as I said here, over 100 slides today. So the throughput is not a problem anymore. Sensitivity is not a problem anymore. So the technology platform that's used today is using semi-automated approaches, gives very good sensitivity, and reproducibility is quite respectable, I would say. So, however, even if you have a very good technology, you can completely screw up by not following some simple rules that Niels gave some examples of. I go through this because I think these are the 3 absolute most important things. There are many other things that you need to consider, but if you look at the clinical samples, and we also did many years ago, basically took whatever samples we could and tried to find some differences between them and so on and so forth. So the pre-analytical variables, which now the BBMRC, which is the Biobank initiative in Sweden and in Europe actually, is doing and trying to put together standard operation procedures you can find on the net, is extremely important. So this is just an example. This is from breast cancer study we did. We wanted to understand the progression of the disease and if we could actually predict a tumor relapse. And in many cases, you have breast cancer samples. That's it. And this just shows you that if you don't keep track of all these different treatment schemes, if they have radiotherapy, if it's neoadjuvant or non-adjuvant, you don't really know what your clinical samples are. So this just shows that it's much, much more complex. So I have a good friend of mine who said they have very many samples from lymphomas. Lymphomas is at least 25 different diagnoses. So the same goes for breast cancer. You have to keep track. I'll just show you very short examples because I have to finish in 26 minutes, which I forgot to start, but I think Rolf.
I'll help you.
Independent patient cohorts. What's that? It's really, this is the way we do it, and this is the way the big company, Roche Diagnostics, for example, do it. First of all, you have a discovery cohort. And in 99% as scientists, we publish that and say we have found new biomarkers. And this is why we have 1,261 in the literature at that time when Lee Anderson wrote his review. However, if you don't take this, what you find here, and then test it in a completely different patient cohort, it doesn't really mean anything. It's a good publication, I grant you that. Good for the CV. But for actually implementing it into the clinic doesn't mean very much. And the next step is then to take it from pre-validation into the next one. So here is defining it, here is testing it, and here is confirming it. If you don't do that, you can just stop. Because you have an overfitting if you just believe what you do. And you can, if you do the defined signature here, and then you test it on the same cohort, it means nothing, really. Also, other confounding factors that are affecting the outcome is basically eliminated by this approach. I'll show you one example. These are genes, unfortunately, but it could be anything. So we looked at 1,000 different markers, and we have 20 samples. We pulled out using p-values
in order to
less
be
than
of interest.
0.05.
And we could see here
analytes
that
from this one here.
In
then we classify them,
cohort
and you can see in a hierarchical clustering, it's a
colorectal cancer patients
perfect separation.
that more than 2 extra.
So obviously we have 50 analytes here, which could be a very nice signature. In this case, it's also for
the patients, so that
for
makes it
cancer
at least
diagnostics.
clinically relevant.
However, if we take these original data then, and then we test them on an independent test set, it completely collapses. And the funny thing with this is, these are absolutely random data. So it just goes to show that you can take any data set, and I can show you perfect separation. If you take that in a independent data set, in a dependent cohort, it collapses completely. And unfortunately, the literature is full of this, showing perfect separation or close to perfect separation, especially in the beginning. Some of the first papers in Nature and Science, it's just like this. If they had go on and done validation, it would have collapsed. So that's the take-home message with that. Then you go into the bioinformatics, and as we had before, you really have to plan that from the beginning, because you cannot do it afterwards, because you tend then to overfit the whole thing. The tricky thing with working with signatures is that I just show you that p-value selection is not a good approach. You can think of proliferation markers. If you have 10 proliferation markers, they sort of, if you look at them as vectors, they point in the same direction. So the information is the same in all 10 of them. So you really have to do it like this. You have to look at the space of information like a balloon, and you have to find all these different vectors pointing in different directions. So each vector here would be a biomarker. And even the little ones here, which have a crappy p-value, could be very valuable in a signature. And this is something that's very difficult even for FDA to understand. And one of the hurdles that we try to explain to them, you cannot look in a signature on the individual biomarker because they are not good enough, but the signature is good. So we developed a way of selecting these, because how do you select them if you cannot use p-value? P-value is really good for biology understanding, but for a signature, you have to do what we call backward elimination. And it's a long story, and I won't go into that, but basically testing all hundreds or thousands of analytes and all the different combination, which is really what you want to do, is not possible. So we use this backward elimination, which basically is that if you have a signature of, if you have a data set, maybe 100 or 200 proteins, you remove one at a time, and then you see how that affects the power of discrimination. And then you remove the other one, and then you do all those eliminations, and at the end you end up with something that looks as the best signature. And what you do is that you look at what's called this KL arrow, Kullberg-Leibler arrow, and in this case we looked at around 150 different antibodies in this case, because we do antibody microarrays, and we remove one at a time, and the arrow here is a representation of how accurate the separation is. So the lower the arrow, the better it is. And this is, if you're interested exactly how we do it, we have an algorithm we can share with you. And these are a number of different data sets that we've done just to illustrate that they all look pretty much the same. So you remove one at a time. The arrow here is very high. There's a lot of noise that you want to get rid of. And then at the end, you go down here and you can see when you removed of these 100, and I think we had 140, if you removed 115 or something, the arrow is the lowest possible, as you can see over here. And this would then be the signature that you test in an independent cohort. If you look at the individual p-values in a signature like this, and they normally are between 15 and 20 different proteins for cancer, and we looked at probably 10 different cancer indications, and autoimmune disease and infectious disease and so on. And they are pretty much the same size, but although different. If you look at the p-values, some of them are very good p-values, some of them you would discard immediately. But it proves the point that this balloon way of looking at it is the right way. So I give you one example. It's pancreatic adenocarcinoma. There is a tremendous clinical need. So the clinical utility here is really very obvious. If you look at the development of the pancreas, this is the pancreas, this is the tumor in this case. The diffuse symptoms are one of the reasons for the late diagnosis. There was a publication some years ago by Yoshida who showed that the development of the cancer is over many, many years. So after the initiating mutation and you find the founder cells and then metastasis, you can see here that we have between 15 and 20 years. However, at the end here, it's only a very short period of time until you're actually dead. And the reason is that you have an exponential growth and only 15% of the patients are operable and the rest are non-operable, giving gemcitabine, and you have an overall survival for 5 years, 3 to 4%. This just shows what happens. There's a 1 year difference here. You can see the tumor here. It's about 2 centimeters. Over here it's actually 52 millimeters. And this is what happens very rapidly. And over here, if you don't treat this, you die within 3-4 months. Okay, so what do? We've taken, in this case, 64 patients. We have a training set. This is support vector machine. We had 120 different biomarkers we looked at in this case. And you can see by plotting them like this, these are the healthy ones, these are the cancer patients. There is an indication. Heat maps are really only for, it's eye candy. They don't mean very much. You can get always very nice heat maps. And in this case, you would say, yeah, they're more red over here, they're more green over here. Yeah. However, if you look at receiver operating characteristic curve, ROC curve, this is really where you have the sensitivity and 1 minus specificity here. This is actually showing the accuracy of your test. And you measure the area under the curve. As I said, 1 is perfect, 0.5 is guessing. And in this case, you can see we have an extremely high area under the curve. And if we take and do the backward elimination, we end up by using 10 different proteins found in serum. We then do the second. We test on a test set, completely different. In this case, we've frozen the signature. And then we test, and you can see that the area under the curve is 0.95. It always drops a little bit. In this case, it drops marginally. And of course, I have also data I can show you area under the curve of 1 with 20 patients, and we actually published that, I have to admit, long time ago. But this one is more recent, and here we've done it the way we should do it now. We tested today over 600 patients in this, so we continued tested on different cohorts from all over Europe, actually, and we still have the same, or very reasonable, around 0.9 area under the curve. And I would propose that this is actually the first pre-validated serum signature for pancreatic cancer. So that's nice. From a clinical point of view, and this is again the clinical utility, if you come to, which we did, talk to our pancreatologist and say, this is really great data, they say, oh, that's fine. But the differential diagnosis for inflammation in pancreas is really what we would like to look at. And there are a number of different types. There are acute, there are chronic, autoimmune inflammation of the pancreas. Okay, so we set out again. In this case, we picked out 68 patients, and this one is difficult to see here, but as you can see, the area under the curve from these 3 types of infection is between 86 and 99. Again, we pulled out 25 analytes, 25 proteins by backward elimination, and then looked at the area under the curve. So this is cancer versus pancreatitis. And as you can see, it dropped, but it's still close to 0.9, and showing again that you can also discriminate between cancer and healthy individuals and infected pancreatic individuals. Acute pancreatitis is not a big problem, but chronic, which is also a pre-stage for cancer, is more important, and the autoimmune is rather small indication anyway. So. Okay, so I don't know if you realized, but just as many people die of pancreatic cancer as of breast cancer in the United States, around 37, 38,000. So it's not a marginal cancer indication. It's a tremendous lethal indication, and the prognosis is dismal if you have this. So, however, the incidence is low, much lower than breast cancer. So we have to find high-risk groups for screening. And in this case, we have, if you have family history, hereditary, infection, chronic, this is a genetic disease, rather small, but you can see that the increase is tremendous. And also here, which is very interesting,
Course, also based on the
many
clinical
reasons,
question,
but
it
if
needs
you have,
to be present in a certain frequency,
diabetes and
in
over
order
50 years,
to be
50 years of
interest.
age,
And we could
this
see
is
here
actually now
that
up to 5 to 8% from a recent study
in a cohort
University of
of
Chicago.
samples from colorectal
And
cancer patients,
the question is, of
that
course,
more than 2 extra
which is
copies,
the
that
hen and
means
which
4
is the
copies
egg.
or more.
But
We
during the first
in
2-3
a
years,
little bit more than
with newly
30%
onset
of
diabetes,
the patients, so
you
that
have
makes it
up to
at
an
least
8-fold
clinically
increase
relevant in relationship to
pancreatic cancer.
frequency.
And of
We
course,
also did a pilot study.
as Niels was saying, you can't get this out unless you have a company in between. So from a market point of view, and it's much, much higher than 600,000. It's millions, actually, in the US and EU. So to convince Region Skåne, another one, people, that this is something that they should look at, we did a health economic study, or we didn't do it, but the Swedish Institute for Health Economics did it. And this is not euros here, so 120,000 euros would a quality cost, quality adjusted life year. So if you have another year of your life, it would cost 120,000, because the incidence rate of pancreatic cancer is very low. So that's out of the question. You really have to look at the risk groups, and this would be diabetic patients, and this would be hereditary pancreatitis patients. And as you can see here, the euro per quality is 17,000 here, 3,000 here. That's almost nothing. And that's if the test costs this much. If it costs this much, then you still have rather low figures compared to what's called the willingness to pay in Europe. So the willingness from the different countries to pay for this varies, but it's around 50,000 euros. UK is lower, Sweden is higher. And obviously we're well below that. So this is, when I talk to a mixed audience of politicians and scientists, this is the only slide that they remember, the politicians. So to get it out, you have to do a health economic study. I was up at Vinnova and reported one of our major programs, and the conclusion they made is that now we have to give money, so you can apply for money from Vinnova for making health economic studies, and that's something for the Diabetic Center to remember. So from the part one is clinical utility. I think is obvious for this case. This I haven't shown you, but if we look at many different indications, there is an overlap of these signatures between 15 and 25%, which is not a problem, because if you have 20, 25 different ones, you can still discriminate. And we have now also started a commercial development of this, and the company is now in Medicon Village, and it's called Immunovia, where the pancreatic cancer will be the first test. How is time?
5 minutes.
Okay, I very briefly then mention a completely different disease, which is lupus, where the problem is really, there are many problems with that, but the clinical issues are diagnosis. They are very often misdiagnosed. So between the onset here and the clinical diagnosis, that could be years. And then you have this active-inactive disease problem, where you have these flares. And if that can be predicted, so that would be the prognostic part, there is, again, clinical utility in SLE. And today there are very few, and if you look at them individually, they are rather poor in the way they perform. So I won't go into this in the same details, but if you look at the American College of Rheumatology, there are 11 diagnostic indicators of SLE. And if you have 4 of these, according to them, you have SLE. And obviously, if you're interested in mathematics, you can see how many different combinations of these actually gives you SLE. This is one of the problems. So obviously here there is a high need for a blood test where you can distinguish without this rather sort of vague combination of clinical symptoms. So what we did in this case is that in this case we have almost 200 different biomarkers we looked at. We looked at 150 SLE samples, and we had 56 healthy controls. Again, doing what I just showed you, test set, our training set, and then we tested on a completely different. Again, using backward elimination, you can see the pattern here, how we work. We froze the signature, and then we tested. And in this case, 25 serum markers, again, show between health and disease, a very high area under the curve. Very nice, 25 of these. And if we do a principal component analysis, this is also a little bit eye candy, but it's very nice. You have the healthy blue ones, and you have the SLE patients here, the yellow ones, and you can see a nice separation. This is just for entertainment. If we then look at active disease and inactive disease versus healthy controls, you can see that we can also characterize that with very high accuracy. So this is the only thing I show you. What I just want to show you is that even complex disease, polygenetic disease, like SLE and cancer obviously, can be diagnosed using this signature approach. And here we have historical evidence showing that single biomarkers doesn't perform as well. And we also have data now that you can actually see if you have an active or inactive disease, which is the first step for a prognostic marker that could then be used for therapy selection, because you don't really need therapy when you have an inactive disease. Many people have been involved, many clinical laboratories. If you work with biomarkers, this should be the most in your acknowledgement, the clinical collaborators. Bioinformatic people, we have, I think what we have the best, at least here in Scandinavia. And yes, this is the road to Denmark, since we have so many Danes. Okay.